of how relating this to the flu epidemic and pneumonia. That's one of the representations of flu in the United States, and it is one that, and you can see by the map on the left side where these concentrations occur. And this is one of the concerns that we have. The reason that that information is 2018 as opposed to 2020 is that in the middle of the pandemic outbreak, although the flu epidemic was rising, we suddenly had the start of the pandemic, and the information, the data, where those two things come together is very, very bad. Because what happens is people think it's the COVID or they think it's flu, and they get the two of them mixed very much. So in order to get a map of what we think will be the flu epidemic in the coming winter, we actually have to go back a year because the data is so interlinked in the 2020 period. We really have to go back to the 18 and 17 period and say, what does that distribution look like before we try to relate it to what the COVID distribution looks like. Now, when we started this analysis, we said, oh, this is going to be easy. There was a fellow by the name of Ben Isaac Israel in Israel, who was head of the Israeli space operations, who said, you know, I have a map or a model of peakedness, meaning where does the peak occur in each of these counties? And here's a model to be able to determine that. And we thought, wow, this is terrific. This is going to make our analysis relatively easy. So here's his idea of peakedness. Here's the kind of model that he has with regard to it. And here's the data for counties in the United States. You can see it's very, very messy. And when we begin to map that, we can see that in early February, later in February, later again in February, later again in February, all those red components are where we see what he argued was going to be the peaks of this particular pandemic in the United States. This shows you what's happened in March, what happened later in March, and finally, what's happened just before April. So these peakedness would be great if that was correct. But what we found was that it's not correct and that we start having problems even as we go forward. It would argue that the peak is over sometime in April and significantly declining, but of course it wasn't. And so one of the classic ways in which we usually model these kinds of things is what you might say is an S-shaped curve or a sigmoidal curve. That is, it starts very slowly, it rises very rapidly, it reaches a kind of asymptote and begins to flatten off. And that S-shaped curve is a model that is commonly used to model various kinds of infections of, in the system as a whole. What we found was that that one does not work very well. But there is a modification of it that's called the Gompertz function. And the Gompertz function is a very simple, we'll go through it very, very quickly, but the Gompertz function operationally is very, very simple. It follows the S-shaped curve at the beginning. That is, it starts slowly, rises very, very rapidly, finds a peak, and begins to decline. And the real issue that we found with things that have high infectious components and where we do not know a lot about the ability of the system to manage the infection is the Gompertz curve, instead of declining to zero, the way it started and the way a traditional S-shaped component would, it has what we call a fat tail, meaning that it gets down there, but it never goes to zero. It continues on out in the system. And as a consequence, there are possibilities of reinfection or re-expansion unless we have mitigations that will drive it further down. And so the Gompertz curve is very important to us. Now, if we look at some data in the United States and we try to fit this Gompertz curve to it, there are three elements of the data. One is those curves that are nice and smooth that you can see on the upper side of these components. And this is simply the cumulative infections, okay? This is simply the number of infections over time. They start very rapidly and they begin to level off. It doesn't mean they stop, but they level off. And similarly, at the next set of curves down below, there's a ragged set of continuous decline. That really represents the proportion of increases every year, every month or every week. And you can see there's a slight decline in those over time. And finally, at the very bottom, we have the raw data that would be fitted to a Gompertz curve, where we have the yellow line rising and then falling again. And that's typical of what we expect to see in most infection systems. So we have a cumulative causation, we have daily cases, we have the slope, which is really the number of new infections which are falling off over time. And this gives us a curve that looks very much like a normal curve, except that it has this fat tail on the right side of the curve. And we can calculate the relative slope that's going to happen over time. Again, same kind of information. Again, exactly fitted. This one is fitted to New York and the New Jersey area. This one is the raw case data for New York. You can see the very great variations in daily at the bottom end in terms of daily, but you can see that slope that cuts through those curves. And at the very top, you can see the cumulative effects kind of leveling off. So this is the raw data. This is not what we hypothesize. This is in fact the raw data that we're looking at and fitting the Gompertz curve to it. And so when you do a log linear plot, that's what you have in the blue curve going down there. That's the log linear plot of it slowing down, if you wish, or the rate of increase decreasing. And again, we can fit this to 2 or 3 different things. And this is what's very, very important when we begin to talk about what kind of information are we using. For example, one of the issues tends to be infections. And infections in the early part of the study of the pandemic was reasonably important. But as we test more and more, we know that we're going to get more and more infections. So it does not mean that infections are disappearing. The infection information is still very, very important, but it means that infections may be a messy kind of data as we go forward. As we test more and more, it means that the infection component is going to rise. And even though infections are rising, the testing will allow it to rise even further. So we have rising infections, but also testing affects that data. So the second information that we have that we do not have here, but I'm working on right now, has to do with hospitalizations. That is, people that are sick enough that get into the hospital, this is in the US system in particular, get into the hospital, are tested in the hospital. We know that infection is there. We have confirmation. We know that some of these people get better and some of these people do not get better. They die. So we have a second component of data with regard to hospitalization. That data is a little bit more secure, but it also is questionable because you say, gee, I'm fairly well off, I'm going to go to the hospital, or somebody says, no, I think I'll ride this out because I can't get into the hospital and it's very expensive and I'm not insured. So there is some fuzziness in this data set as well. And finally, the last data set we have is deaths. If you're dead, you're dead. It's not a question of discussion, you're dead. Now, the only discussion there is, did you die because of COVIDs or did you die for some other reason? And the analysis of COVIDs allows us to really make that decision, usually an autopsy, often other information. but that data is pretty good. So we know the number of people dying from COVIDs, and that's pretty solid information. It may be a little inflated at certain times, but it's pretty strong. So the reason raising all those issues is that when we're going to design policy, we have to talk about what kind of information we want to lean on. And so that's one of the reasons for spending a little time on that. Now, when we begin to look at this in the United States, and this is true in China, it is probably true in Pakistan, it is true in very large countries that have a lot of spatial extent. There are differences in different regions. You remember I talked about New York and New Jersey, and then I talked about it spreading across the country. It does not hit the whole country at the same time. Now, it is also true that the United States is a federal system, which means that states are very, very important in the decision process. And there was made an early decision on the part of the central government, i.e. the president, to turn most things over to the states. This is both bad and good. It's good in the sense that it articulates what the issues are in that state and what they should be doing. It is bad in the sense that the rules end up being rules that are different in different states. If everyone stayed put in the state that they're in, this would probably not be a big issue. But if people move around a lot, which they do in the United States, then these regions affect each other. So if we look at the United States as a whole, and sorry, I'm running out of time, but we look at the states as a whole, we can see particular regions. So here's the north central states in the United States, the middle Atlantic. You can see the kinds of distributions that are occurring. And this is over the period up to, including into the end of May. You can see the declines with regard to that slope we talked about. You can see the raw data, and you can see the cumulative effects and the death rates. So we have infections and death rates looking at this. This is now the New England region, the north of the area before. This is the area in the South Atlantic. I would draw your attention to the fact that the slopes are there, the nice curves, but notice that the data is starting to get a lot messier. It's starting to be much more jagged than it was before. And as we go to the southern part of the United States, this is where a lot of decisions were made on the part of governors when they were given either not to close immediately or to not lock down or to leave everything open, or when they did close, be only closed for 2 or 3, 4 weeks and open immediately. And the result is you can see what happens to these daily infections. The same occurs less so in the Midwest. And finally, the North Central. Now, this will give you some idea again of the South. You can see on the right side, the East-South Central Division is getting very, very messy. This is what we call the southern beginning of what we call often the southern tier. And over time, it has been the southern tier in the last month that has created havoc with regard to these models because of all the differences across these states and the fact that they're very, very different than other parts of the country. The Pacific. And finally, I just did something in my region, which is the Washington, D.C. suburbs, and fitting curves to those. Now, this is the end. There's a series of unresolved issues here that are very, very important. One has to do with the differences across the country. So we see New England, the Northeast, being relatively well managed and managed in the sense of they resolve that curve much, much like we expect it to be resolved. The Midwest, also not too bad, but the southern tier of the United States, from Florida through Texas, is in expansion terms a mess. That is, they've been expanding very, very rapidly all the way to Arizona. And so one of the big questions that's coming up now has to do with what we call herd immunity. And this has to do with what proportion of the population needs to be infected so that the infection rate will begin to slow very, very rapidly. And there's lots of counter discussion between some number in the neighborhood of 20 to 25% to a number as high as 65 or 70%. The real number tends to be on the low side, probably, of that. But this affects what we're going to do in what parts of the country. There's probably something close to 20% in Florida at the present time, and very rapid expansions. Last, the thing that drives all of this that we've not looked at, and the Hopkins material does not look at very effectively, is metropolitanization. Metropolitan counties are going to be hit harder than others. It's the density component, and therefore the management issues with regard to it are very difficult and very important. So when we begin talking about policies, we have to differentiate A, different parts of the country, B, different kinds of clustering that takes place, C, issues of metropolitan or concentration. And last but not least, we need to look at what might happen in the coming 6 to 8 months, which is where influenza is liable to be on top of this COVID distribution. And what we know about that. Now, what we found in preliminary data is that we hypothesized that these two distributions would be on top of each other, that where we got high influenza distribution, we would get high COVID distribution. And so far, our data shows that that does not appear to be true, that they're not on top of each other. And that is probably because we have different mitigation strategies for influenza, in particular vaccination. And that's available across the country. It is used in some places more than others, but it creates a different distribution. And therefore, the issue of where this overlap will occur is a major issue and a major question that's likely to occur. And I'm going to stop there. Thank you very much for your attention. It's very, very kind for you to listen to me.